Thanks very much, Kieran. I'd just like to welcome everybody who has joined us online on behalf of Loughborough University, and thank the Institute of Advanced Studies for allowing us to fly Cisco over from Switzerland. So the Peterhausen Centre for Disability Sport has had a long-standing relationship of working with people from the Swiss Paraplegic Research Centre, for which Siska was based, and now she's elsewhere in Switzerland. But we've kept a real sort of close working network with her, and the reason why she's over is sharing her knowledge not only in this presentation, which is looking at the shoulder health in wheelchair athletes, but also to collaborate with us on future work around athlete health and some of the work that we're currently doing with GB Wheelchair Rugby. And Tom O'Brien has facilitated a really nice sort of data collection opportunity for us to collaborate with Siska. We'd like to thank everyone for coming in the room here as well to join this particular session. And I know Siska's got a little bit of the introductory slide of who she is and where she's come from. So I'll pass the floor now back to Siska and say thank you very much for joining us today.
Thank you very much. Thank you everyone for coming, and also from my side, I really grateful for the invitation and the support from the Institute of Advanced Sciences, as well as Vicky for inviting me for coming here, and Tom O'Brien for the organization of the assessments. It's been a truly great pleasure, and I'm really excited that I can talk a bit more about shoulder health in wheelchair athletes and what I've been up to.
I'm sorry, I need to go back. Okay, go ahead.
Okay, so just a bit of an overview about my talk. So I'll start a bit with my background, then I'll talk more about shoulder health in wheelchair users, and specific followed by how fatigue in wheelchair propulsion impacts, also injury mechanisms, which we're trying to better understand to improve injury prevention and monitor rehabilitation, which will then lead into future perspectives and what's missing, where we want to go, and also what I'm doing in my current role at the ETH in Zurich. So I'm originally from Belgium, from a very small village where it's very flat. I studied science and mathematics, and then I went on to study bachelor and master in physical education and movement sciences at Ghent University, because I've always been truly passionate about sports and how that is instrumental in good health and happiness. I did an Erasmus exchange in Finland, got more introduced to the topic of biomechanics, which I really like because of the interconnection between physics and the human body. So I decided I wanted to know a bit more about that, and I went on to Liverpool at John Moores University, where I did the Masters in Sports and Clinical Biomechanics, looking at fatigue injury mechanisms in landing strategies, so in the lower limb. After that, I went back to Belgium, volunteered at the university, got a research assistant position, which then brought me to my PhD at the Swiss Paraplegic Research Center, which I'll go talk a bit more about in a minute. And this was in collaboration with the University of Lucerne in central Switzerland. During my PhD, I also collaborated with the University of Pittsburgh. I went there twice for a research visit, which is where I learned the quantitative ultrasound protocols, which I'll talk more about as well, and which is what we have been doing with the wheelchair rugby athletes during my stay here. So after that, I had the feeling that I wanted to better understand, we're looking at these shoulder tendons, but what is actually happening? Why do we see these changes? So I wanted to get more into fundamental biomechanics and learn more about muscle tendon interactions. And this is what I did in Calgary, at Calgary University, where I did more animal research, really directly measuring muscle forces, tendon strains during a locomotion in vivo. I then came back to Switzerland and wanted to apply this more fundamental research back to the human side. Came back to the Swiss Paraplegic Research, continuing my work there. And now since September, I am at the ETH in Zurich in the Laboratory for Movement Biomechanics, where I'm leading the shoulder project within the laboratory. And during this time, what I didn't really mention is that as I started my master's in Liverpool, I also started rowing, and I feel it a bit as my biomechanics journey evolved, I always continued rowing, and I've been also a para coach in rowing and involved in the inclusion of para rowing at the Luzern Regatta, which organizes the World Cup, and this year the last qualifying regatta. So at the same time, I'm still applying a bit of my sports background and the shoulder work. But that's enough about me. The Swiss Paraplegic Research, I'm not sure if you have been there already or you may know it, but it's in central Switzerland, and it's really a unique set of resources that overall aims to improve the lives of persons with a spinal cord injury. And this goes from the date of injury, acute care, rehabilitation to reintegration into life. And the Institute and the Foundation really value the importance of sports as a way of a reintegration into life. So you also have the sports medicine, who's supporting a lot of Paralympic athletes, but going from any level, so from recreation to a competitive level. And then they also have the research center. So the research center is based in this F-shaped building here, which stands for Forschung, which means research in German. And within the research center, I was part of the Shoulder Health and Mobility Group, which aims to improve mobility and shoulder functioning in persons with spinal cord injury. So this is fundamental because as injuries occur, it has a direct impact on independence, mobility, quality of life. And unfortunately, unfortunately, the shoulder is prone to injury, and it's one of the most common complaints are related to the shoulder joints. Now, the shoulder is a very fascinating joint. It's the only joint in our body that allows for such a great range of motion, and this is because of the limited stability, anatomical stability, which requires stabilization from the muscles surrounding the shoulder. Now, I want to give you a little task, and also those who are listening online, if you have a TheraBand or an elastic, I'll give it around here, but please try to do as many repetitions as you can. So you are in your elbows, 90 degrees of flexion, and you will do an external rotation. So it's pretty hard. I don't want you to go maximum, but try to do as many repetitions as you can, and then afterwards we can get back to that. So I'll put that on. So yeah, we really need these muscles to stabilize our joints. So the prevalence is high in the general population. It's ranging up to 2/3 of the population. So up to 2/3 of the persons will have shoulder pain at some point during their lives. In persons with a spinal cord injury here, the prevalence is up to 73%. So it is higher. We also see a high prevalence of rotator cuff abnormalities in persons who are performing activities that are specifically demanding for the shoulder. So that includes wheelchair users. So almost all wheelchair users will have some rotator cuff abnormalities. Also, for example, professional basketball athletes. Now, we don't really have exact numbers about wheelchair athletes, so it would be interesting to see more closely how performing these wheelchair sports impacts the shoulder tendons, and how that may be different in persons who are performing less sports or maybe less trained at the shoulder. So we know that tendons degenerate over time, and as you age, you will have more degeneration in your tendon. As you can see on this figure here, we go from less than 20 years old up to 8 years old. We see that 60% of the population has some tendon abnormalities. If we look at wheelchair users, we can see that persons who are in a wheelchair who are about 40 years old, their tendon abnormalities will have accelerated as compared to someone who is not in a wheelchair. So they would have tendon abnormalities similar to someone who is above 70 years old. Now what we want to understand is how that relates to pain. That may not necessarily mean that it leads to pain, but we want to better understand what exactly is causing the so-called acceleration of degeneration. So I spoke about these muscles that are supposed to stabilize the shoulder, and they're called the rotator cuff muscles. So they form a cuff around the shoulder. So the shoulder is really mobile, so we can do a big range of movements. And if there's any instability in this muscle, in these muscles, that can lead to an overloading at certain points and lead to injury mechanisms. So we can look at the shoulder a bit as a seal who's floating on the water. So the shoulder blade is floating on the thorax, and then it's trying to balance a ball on its nose. So the seal this would be the seal, the shoulder blade would be balancing the ball of the humeral, so the humeral head on its nose. So the scapula has to move dynamically so that the humeral head stays balanced on this point. And that is done through these muscles that form this cuff and try to stabilize this joint while you're doing all these movements, which you can imagine it is demanding and very complex. So the most common diagnosis is related to the supraspinatus and the biceps tendon, which are these tendons that lay within the subacromial space. So they are between the humeral head and the acromion, which is part of the shoulder blade. And as we're moving our shoulder, for example, overhead, we reduce the space, and this could potentially lead to compression of the tendons. In combination with repetitive activities, so for example, if we are propelling a wheelchair, we're doing these repetitive activities, but we also have this reduction in the subacromial space. And animal work has shown that it's especially this combination of overuse and compression that leads to the greatest injuries. But we don't know if that is how that specifically works in, for example, in human mechanisms. So if we have a healthy tendon, we see these nicely aligned collagen fibers. And on an ultrasound image here, we can see a biceps tendon. So the biceps tendon is visible in between these nicely distinct white lines. And we can see these nice black and white lines, which represent the collagen fibers. So with aging, but also with overloading, so potentially repetitive overuse, combination of compression, we can have degeneration, so tendinopathy, which would lead to disorganized fibers, capillary ingrowth, maybe some fluid in there. So on an ultrasound image, this would look a bit more like this. And so the tendons adapt to our changing demand. So we may have some acute injuries, but it can recover over time. So it's not that these changes would be permanent. However, if we constantly keep overstressing the tissue, we can get to a stage where it's the changes are irreversible, and this could lead to tendon tears, tendon rupture, which would then require potentially even a surgical intervention. So we don't really understand how we go from these nicely healthy tendons to the tendon degeneration. So what are the exact steps leading to these chronic problems that are then irreversible? And the problem or the difficulty in understanding the mechanisms is that a lot of persons who have degeneration in their tendons are asymptomatic, so won't have any symptoms. And this can be for quite a long time. So the duration of being asymptomatic is inconsistent, and it doesn't necessarily mean that if you have abnormalities that you will become symptomatic. So we don't really understand who are these persons who have this degeneration that will get symptomatic. So we want to identify who these persons are so we can prevent injury to happen. Now, one interesting parameter that has been found is this so-called critical shoulder angle as a risk factor for, or a predictive factor almost, for being someone who would develop rotator cuff pathology or osteoarthritis. So if you look at the critical shoulder angle, which you can see here as these yellow lines, it's the angle between the inclination of the glenoid, so that's part of the scapula of the shoulder blade, and the top of the acromion. If this angle is above 35 degrees, over 80% of the subjects, so that would be here, were found to have rotator cuff pathologies. While if the angle was below 30 degrees, over 90% of those subjects had osteoarthritis. And this is hypothesized to be associated with the mechanism that if you have a larger critical shoulder angle, you need more stabilization from the rotator cuff muscle, so there will be more stress on those tendons, potentially leading to tendon degeneration. While if this angle is much smaller, it changes the vectors with which the muscles are pulling on the humerus, so you'll have more compression in the joint, which would be expected to lead to osteoarthritis. But we don't understand how this critical shoulder angle or how this affects stress on the muscles and the tendons during motion. So these are assumptions that are made, but we don't really understand the mechanisms behind these risk factors and how the moving scapula plays a role in the load distribution on the muscles and the tendons. So if we want to improve injury prevention, we want to get to these risk factors, these predictive factors, so that we can really target our injury prevention strategies. And previous research has shown that risk factor for shoulder pathology and pain in wheelchair users include both, and this is straightforward, the demands on the shoulder, but also the capacity to meet those demands. So this has to be in balance. And so, for example, factors associated with capacity would be sex. Females have almost twice the odds of having shoulder pain as compared to males, as well as the injury characteristics. So depending on what kind of impairment you have, that will impact your shoulder loading. Also, this space for the tendons, there's more space for your for your supraspinatus, your rotator cuff tendons. This would be potentially beneficial. Range of motion, also your muscle strength, how is it stabilizing your shoulder? Time since injury would also be injury mechanism, and then age, obviously, as well. Then the demands on the shoulder relate to the shoulder loads. Also body weight, the heavier you are, the more you will have to push yourself forward, transfer every time. So even those little changes can have a significant impact on your shoulder loading. The propulsion biomechanics, so there are guidelines in terms of how it's been recommended to propel a wheelchair, because that is then associated with less shoulder loads, as well as a wheelchair and its setup, as we're doing bike fitting for cyclists. That obviously plays also a significant role in minimizing the demand, so that you can then optimize or have more room for using the loads wisely, so that, for example, if you optimize all these factors, you can invest more in playing sports and then get also more your aerobic capacity improved, instead of then sort of losing energy on a bad setup of a wheelchair. Would be unfortunate. I'm not sure if we're taking questions in between or something.
Oh, we'll come to the end if that's okay.
Okay, yeah, so to the end, yeah, that's right. So the recommendations in terms of propelling a wheelchair, as it has been shown, is that it's really recommended to propel a wheelchair with these long and these smooth strokes, so not have these short forwards and backwards movement, but really do the circular motion, because that reduces the stress on the shoulder. So these two styles on the right hand side we believe require these less muscle forces. In terms of rehabilitation and strengthening the shoulder joint, there's the STOMPS program from the group in the US at Los Angeles Rehabilitation Center, which has been shown to reduce shoulder pain and be effective in wheelchair users. So it includes 3 stretching exercises recommended to do 2 sets, holding each position 20 seconds. And then which would then be followed by an exercise program. So you do a warm-up where you have 2 sets, 10 repetitions of each activity without resistance, and then doing these activities, so including hypertrophic exercises, as well as these endurance exercises, which are really helping to stabilize the shoulder joint and having this balance at the shoulder. And they are applying this protocol as an intervention, so also comparing the effect of when you do a home-based intervention versus more interaction with the physio, and this has been shown to be a really effective program. So this is, for example, also what we're applying with wheelchair, with the rowing, para-rowing athletes, but then making the exercises more functional, so you can do the activities within the position on the ergometer, so that the athlete is immediately in that position, which will be more sports related and more effective, saving time in general for the protocol. And I think this is something that we know that is there's 4 exercises that can be implemented, can be given with the athletes, and that is already a great step in terms of prevention. Now, despite all the advancement in science that have been that we have reached over the last years, and the increased interest also in shoulder research in research, as we can see, there's a significant increase in the amount of publications over the last years. There is still a lack of, or the treatment, surgical options are still unsatisfying in a way that there is still quite a high re-rupture rate following surgical treatment, and the prevalence values are still high. So this raises the question, what should we do differently? Like, we're doing so much more research on the shoulder, we're trying to understand what's happening, but what are we still missing? And one idea is this idea of early identification of those persons who will become symptomatic over time, because we have this difficulty in actually diagnosing persons who have pathology that is asymptomatic. We don't want to be worried about every person who has some kind of tendon abnormalities, but we want to really understand who are the ones that will become symptomatic. And this early identification is something where I'm really interested in my field of research. So we, in my PhD, one of ways to look at that is to look at fatigue and how it impacts the shoulder structure. Because with fatigue, so this complex phenomenon in which physical and cognitive functioning is limited to interactions between perceived fatigability and performance fatigability. So performance fatigability would be a reduction in maximum strength, a change in heart rate, a change in muscular activation. Perceived fatigability would be a change in perception. So during this state, our bodies are particularly prone to adaptations. So it offers a great way to see how our body's changing with fatigue, so we can see these acute changes to better understand how that may lead to chronic adaptations. So we studied fatigue in a broad sample of persons with a spinal cord injury, ranging from persons who are inactive to para athletes competing at Paralympic level. We investigated fatigue with this figure 8 fatigue protocol, which includes 3 times 4 minutes of overground wheelchair propulsion. So including these right, left turns, starts and stops that would mimic more what we do during daily life, but also wheelchair sports related training and activities. And then one thing that we found was that if we look at the startup propulsion biomechanics, because this is really demanding, if we accelerate the wheelchair, we get the highest forces. And we did see changes in the propulsion time on the wheel at this first stroke of startup propulsion. So while there may not be changes of fatigue overall, at this first stroke seemed to be very critical, which is important because that's what we would be doing more generally. And also persons who were propelling with these less advised propulsion styles were found to show more signs of fatigue. So again, reinforcing to propel with these long and these smooth strokes. And for that, we used this smart wheel, which is a wheel where we can measure the forces on the push rim, so we can actually get biomechanics of propulsion. Now this study was done, this study was done in the US, in Pittsburgh, but then we also collected data with 50 wheelchair users at the Swiss Paraplegic Institute. So this room that you're seeing here is the laboratory there, that's based within this F-shaped building. So we had a combination of several assessments that were conducted before, during, and after this figure 8 fatigue protocol, which we did in the corridor. Overall, it took about 4 hours. So we did maximum tests, maximum sprint tests, maximum push tests. We took ultrasound exams just to better understand what is happening. We also looked at their propulsion biomechanics before and after the fatiguing task on the treadmill, because that's how we can standardize the power output. So all persons were propelling at fixed power outputs, and then we would see if their propulsion biomechanics would be affected by the fatigue. So looking at muscular activation and so on. So the ultrasound examinations in specific that we use, and these are also the ones we have been doing with the wheelchair rugby athletes, include, so here in Loughborough, so these assessments include the acromion distance. So that is the space between the acromion, so the shoulder blade, and the humeral head. And we did that in a neutral position as well as in a push-up. So we had a push-up where we asked to retract the shoulders, as well as a push-up that where we didn't give any instruction. So their style of pushing up. We also looked at their biceps and their supraspinatus tendon. And these protocols, so these quantitative ultrasound protocols, allow minimum error in probe location before and after the fatiguing task, because we stick a metal marker to the skin, which gives a reference pattern on the ultrasound image. And from there, we can then calculate the region of interest from which we can then quantify the average tendon thickness, but also the grayscale and the contrast, we see nicely distinct fibers. So what we found was that after the fatiguing task, persons were propelling with shorter strokes. So again, confirming that this is something that also with fatigue, we're changing our propulsion biomechanics to this more demanding task. And we also saw an increase in neuromuscular activation in specific muscles. So in the pectoralis, the deltoids, and the upper trapezius specific, so the upper trapezius part here, so this also is green, is the lower and middle trap, but those muscles were mostly affected by the fatiguing task, and that could lead to muscle imbalances over time if we don't complement it with exercise training that would then also strengthen the muscles surrounding the shoulder, so that we keep this nice stable base for the shoulder joints. We then also identified persons susceptible to fatigue, and this was associated with injury mechanisms, so persons who had a complete lesion, who were older at the age of injury, but also persons who propelled with these shorter, less advisable strokes were more susceptible to fatigue, persons who had less muscular activation, as well as what's interesting was that persons who had a greater anaerobic capacity with no differences in activity levels were more prone to fatigue. And this may be associated with the fact that athletes who train for anaerobic capacity in general are more susceptible to fatigue as compared to athletes who train for aerobic capacity, really demonstrating the importance of complementing the training protocols. If we looked at the acromiocumul distance, what was interesting here was that we found that in general, persons who would push up would show a reduction in the supracromial space, which could potentially be a risk factor for shoulder problems. Now, those persons who had a greater anaerobic capacity were actually able to maintain the acromiocumul space. So really supporting towards the value of muscle strength training, doing performance, also sports, to have this capacity as a way to strengthen the shoulder joints. When we looked at the tendons, we found an overall reduction in the supraspinatus tendon, which is a natural response of repetitive activity to tendinous tissue, so alignment of the collagen fibers. However, interestingly, persons who are heavier actually showed an increase in the thickness. So this could point towards that a natural response is this reduction, but if you have this overloading because of your body mass, potentially that could lead to overuse at the tendon level. So in conclusion here from this specific research, it really supported the propulsion technique, but also aerobic capacity, potentially using high intensity interval training, but also anaerobic capacity values of for maintaining, not only, but as one mechanism thereof would be maintaining the acromiocumul distance, and also the importance of neuromuscular activation. Now, what's interesting is that as I did this work and I presented it, and as Vicky said, they had collaborated before. I'd been collaborating with the Swiss Paraplegic Research. Vicky then suggested to also apply these methods to the wheelchair rugby athletes, and that's in 2020. I came here and we collected data, and now we'll have a second time point where we are looking at the shoulder tendon. So applying the same protocols, but then looking at that time, we looked at the effect of a maximum test to exhaustion when the athletes are in their sport-specific wheelchair, and propelling, how they would be propelling during a gameplay, although it is on a treadmill, but given that it is the maximum test, offered us unique insights also with the addition of the physiological information. So interestingly, what we found from these studies was that we saw a reduction in the echogenicity grayscale, which points towards a reactive tendinopathy mechanism. So this would be a sign of overloading, which is what we were to expect if you're doing a maximum test to exhaustion. Now, the interesting part there as well is how fast do the athletes recover? Do the tendons recover? How much time do you need until you can, for example, do such tests again? We also identified differences in the supraspinatus thickness between athletes with different impairments, which also points towards this importance of differentiating between different impairments, and the need of really more research into this field, because we are really limited what we know to date. We also had one specific case where we looked at a left-right shoulder in one athlete who was asymptomatic on one side and symptomatic on the other side. And I think this is a very interesting topic as well that has been researched also by the group here in Logra, these asymmetries. And what we found was that, interestingly, while the symptomatic side had a higher peak power, there was a greater drop in peak power, so a greater fatigue index in the symptomatic shoulder. And we did see that in the asymptomatic shoulder, we saw this reduction in the supraspinatus tendon, which we didn't see in the symptomatic side. So there were some asymmetries. Could be that, for example, due to this increased fatigue index at the symptomatic shoulder, maybe the asymptomatic shoulder may have to overcompensate. This could lead to problems over time, but just trying to better understand the mechanisms and what's happening, how we can inform the coaches and the physio with this information would be extremely valuable. And so last week and this week, we're collecting more data with the wheelchair rugby athletes. So this is a picture, and it's been really a lot of fun with everyone working together and having such an interdisciplinary team. So hopefully next time I can present you some of the results like that. So what are now the future perspectives? What are we still missing? Where do we want to go? First of all, we know there are these acute tendon adaptations, even after a maximum test exhaustion, after fatigue protocol, we see changes. So how do these changes now play a role on the long term? Can we, complete that full picture from healthy to chronic degeneration? And what is the impact of the impairments of the sports, the position in the wheelchair, and also how is that different following training competition? In addition, what we really need to understand is how the muscle forces impact the tendon strain, because the tendon is immediately impacted by the muscle. This is why I went to Calgary to try to better understand it, but it's just impossible in humans to directly measure the muscle forces. So we rely on assumptions, on simulations to get to this kind of information. But what we really want to understand is this dose-response relationship. What is the appropriate amount of loading? Because specifically for the tendon, overloading can lead to micro damage, but complete removal of load leads to a catabolic state. So what is exactly the perfect amount where we can improve the integrity of the tendon without degenerating it? So this early identification of tendon degeneration, which could then be used to monitor rehabilitation and injury prevention. And I think the biggest limitation to date is the lack of sensitive technologies and assessments that can actually identify someone who is asymptomatic and has degeneration. And this is what my work leads into, where I'm going now, also to understand how the scapula is exactly moving, because even a 1 to 2 millimeter change in the shoulder blade position can lead to up to 67% reduction of the subacromial space. So pointing towards current methodologies, motion capture systems, where we have markers on the skin are just too limited to identify such subtle changes. And that's why in recent years, there has been an increased interest in groups that are working with dual plane fluoroscopy systems. So it's basically an X-ray system where you can see the shoulder blade during motion. Now the systems to date are limited in that they are static. Patient has to remain stationary, and we cannot really do very functional assessments. And there haven't been any estimations of the actual strains on the tendon. As I said, we cannot directly measure the forces in humans, but we need to get to those load mechanisms. So at the ETH in Zurich, at the Laboratory for Movement Biomechanics, they have developed a unique tracking dual plane fluoroscopy system, which is such dual plane system, so which has this X-ray that tracks the subject wirelessly as moving through the lab. And they have been focusing on the knee and done very fascinating experiments with persons who have knee implants, where they can then actually have the forces as well as the motion of the bones. So our goal is to apply this to the shoulder and get to more functional assessments to actually see how the shoulder is moving during these functional assessments. Now, it's clear that we have to be cautious here about the radiation dosage and that this is still invasive, even we try and we minimize the radiation as much as possible. On the long term, we don't want to have everyone coming into a fluoroscopy system. So that's where we also developments lead towards non-invasive assessments that can help us. So for that, we're collaborating with the University of California in San Diego, who has developed this stretchable ultrasound technology, which is basically like a patch that you can tape to the skin and can then get ultrasound information up to 4 centimeters underneath the skin, as well as modulus, so get strain information of the tissue. And they have shown, they have done experiments where they had athletes, they had the patch on their shoulders, followed them before and after eccentric training. And what you can see here is that as they have the eccentric exercise and then they've applied natural recovery or different recovery strategies, that they can actually reduce delayed onset muscle soreness with these recovery strategies. So this would allow, if we apply it in a wheelchair athlete populations, you could have the patch in a training week, see how the tendons are changing before, after training, before, after potentially gameplay, which would be revolutionary in terms of monitoring their tendon health. Then we have also the in silico and in vitro simulations, which can then, if we combine the technologies, give us this information on the forces and the tissue strain. So for that, we're collaborating also with a group in Sydney at Macquarie University, who developed a advanced shoulder simulator and to actually measure the muscle forces when simulating these shoulder movements. Now, the final part would be the non-invasive optical tracking. So from the fluoroscope, we want to go to non-invasive scapular tracking using a technology that has been developed to quantify spinal alignments. And we want to apply this to actually get the information of the scapula moving using then machine learning and deep learning methods. So combining all of these technologies, the projects that I'm working on aim to shape innovation for shoulder kinematic assessments, leading to then a biomechanical understanding of soft tissue loading and injury in vivo, hoping to then improve injury prevention and rehabilitation. So thank you very much, and I'll be happy to answer any questions.